All right, I'd like to thank the moderators and sages for the opportunity to be here and talk about this. Can I just quick get a poll? How many people in here are doing poem in their practice? Okay, so a fair few. I am going to talk through technique a little bit for those of you who are maybe less familiar. So we'll look at the technique and the outcomes of poem and talk a little bit about, one, how poem has some benefits compared to Heller myotomy, and also how it's an enabling approach that can let you do some things that you may not be able to do the other way. So I like this quote from John Hunter: "Surgery, gaining much from the general advance of knowledge, will be rendered both knifeless and bloodless." And while poem may not be bloodless, at least we're halfway there. And also, maybe we can get Ezra to get Dr. Karillis to write a new review from whalebone to endoscope. We'll see if we can do that. So the treatment strategies, we talked about Heller and pneumatic dilation. I think poem, the most appealing thing about poem when it first started and even now is the possibility to take some of the advantages of these two procedures and bring them together and kind of gather the best of both into one spot, although that doesn't come without a cost potentially on the reflux side. So like I said, this was described in 2009 by Dr. Inouye. It's done in the OR under general anesthesia in the supine position. Very important to use CO2 insufflation. I had one case where they had the air turned on, we didn't catch it, did the case with air insufflation. The patient got a big pneumothorax, we had to put a chest tube in. Guess what, she did great from her poem, but had pain for months and months from the chest tube site. So that's a pretty important point. So to start, you want to do your endoscopy, irrigate the esophagus. We keep people on a liquid diet for a few days before surgery to try to prevent buildup of food. We open the mucosa about 13 centimeters above the GE junction, higher if you're going to do a long myotomy for type 3 achalasia. Important point here is to get all the way through the mucosa and submucosa to the muscle. So you want to see the muscle fibers before you start trying to take the leading edge of that cap and deflect the mucosa. So you can do that in the posterior and deflect the mucosa up. We do it anteriorly in the midline and deflect the mucosa down. Then once you get into this submucosal space, making that tunnel is pretty easy. You just have to watch out for blood vessels and bleeding. The trick then, once you make your tunnel, you want to make sure you get down onto the cardia of the stomach, just like if you're doing a Heller myotomy with the laparoscope. Ways to do this, you look for the vessels at the GE junction. The space will open up once you pass this, the LES, the measurements from your endoscope. And we like to transilluminate. So we have the standard endoscope in this tunnel down at the bottom where we think we're finished. This is a NP narrow scope in the stomach looking back, and you can see that our submucosal tunnel is nicely down onto the cardia of the stomach, and that if we do our myotomy to the end of the tunnel, that we'll have a good complete myotomy and be happy with that. The myotomy itself, you can do this a couple ways. You can hook the muscle down. I like the triangle tip knife because it's easy to use for that. So you can do it either way. You can hook the circular muscles and pull them down. You can also arc to them from below and they will split. And you see those nice cut edges just again like we would see in a Heller myotomy just from the other side. And then at the end, we do an endoscopy very much like we would do after a Heller. We clip the incision closed. I don't have that here. But at the beginning of the case, the GE junction is tight. It's hard to pass the endoscope. By the end, you should really be able to see across it just by insufflating a little bit with the scope. Should be really nice and open and easy to pass the scope. You always want to check the abdomen. You can get a pneumoperitoneum built up during the case about maybe 20% of the time. We put a Varus needle there and evacuate some pneumoperitoneum, so that's really common. Post-operatively, we admit them to the hospital, and I plan to keep them overnight, but if they're feeling good in the evening, taking liquids and feeling all right, I send them home the same day. I don't get routine swallows anymore. We did for the first 50 or so and then stopped doing that. This was our published data from our first series of poems we did. So we found good initial responses out to 6 months. We presented our 3-year data at Academic Surgical Congress this year. That was pretty similar. If you look at GERD, health-related quality of life scores, they actually go down because they get a lot of regurgitation symptoms preoperatively that aren't reflux related, but the scores on these metrics afterwards are not that high, and that actually whether they're on PPIs or not, and that's gonna be kind of an important point when we talk about post-op pH studies. Quality of life, we saw global quality of life improvements at 6 months. Some of those don't hold up so much, but some do out to a year and 18 months. This is the same, some of the same comparative studies actually that we were looking at. You see pretty similar responses in terms of dysphagia and pain for both POEM and Heller, and improvements in quality of life, so very similar outcomes. Here, this was Lee's trial that we already looked at. I'm going to skip that one. Objective testing. So when we started doing POEM, we had concerns, or I did, that we didn't really know what that reflux rate's going to be. We don't know how people's symptoms are with achalasia and GERD. So we routinely did pH tests. In our series, we are pretty aggressive with the myotomy. They're positive pH studies about 58% of the time, so it's a high rate, but over half of those positive studies, the patients didn't have symptoms. So you look at the correlation between the GERD, RQL, and other symptom scores, and it's just not there. So symptoms alone really can't tell you if people need to be treated for reflux with medication or not. So I think it's pretty important to do pH studies. This is a study from a group here in town at Swedish, and they found a very similar thing, that the reflux rates are significant. They weren't quite as high as what we saw in our own series there, but importantly here they're actually similar between POEM and Heller. So you see some pretty disparate publications about reflux rate after Heller myotomy and fundoplication, and I think there may be a tendency to underestimate that rate, and that's something that will continue to be an issue. Durability, this was a paper that was published from Northwestern, just looked at studies that had longer term follow-up and have shown that to date, POEM does have, its durability is pretty good, and once you get out of that initial experience from some places, that it starts to look a lot like Heller, and we'll just have to keep watching that over time as the procedure matures. This video I wanted to show because this is a patient who had type 3 achalasia and underwent a lap Heller, had continued dysphagia after that, and had a pill study done, esophagram, and the pill hung up in the esophagus above the level of where the myotomy was. Once the tablet got down lower, it passed right through. So we went and did a POEM, and we made our incision in the mucosa high up around just past 20 centimeters. Did our tunnel all the way down to the GE junction, and you'll be able to see here, once we get past the tunnel, we can see the old myotomy, we can see the edges, and we were able to start high up, do a long myotomy, and meet the previous Heller myotomy. And that she still had chest pain that persists after that, like a lot of these patients, but her dysphagia did get significantly better. So I think this is an example of where your only other alternative from a surgical standpoint is to do a thoracotomy or a more highly morbid procedure in order to address this problem, where POEM gives us a less invasive way to do that and actually expands our toolbox a little bit. I would say I think that when you think about lap Heller and POEM, doing POEM for patients who have hiatal hernias is probably a bad idea because you're asking for trouble with reflux, plus just doing the operation, straightening everything out and doing that laparoscopic myotomy is likely to work better. So that's a setting where I wouldn't use POEM. And here you can see the previous myotomy here. You can see the edge, and we'll come back to where we did our myotomy up high. So I think right now the important thing here, and probably maybe the most important thing to take away from this whole part of the panel, is that it's a complicated disease. People have a lot of different problems, and probably having more treatment options in your toolbox is important. And I'm going to stop there. Thank you.